Thanks, JB and David, and thanks, Sages, for the opportunity to give this talk. I'm going to talk a bit about dealing with complex problems like these three scenarios. I do have disclosures, but shouldn't be pertinent to this talk. For a long time in healthcare, we have been under a model, a paradigm that says we as the doctors need to decide what's best for our patients. And I think in the last decade or so, we've seen this patient-centered care kind of swing the pendulum, but it's been, I think, a very naive interpretation. You know, the patient, as has been described in this session, doesn't always have a full understanding of the situation. So we can't just have the patient decide everything. And in the United States, we even have some influence from payers and from our hospital contracting to determine what is available for us to treat our patients. And I think this is just a mess. It's not what we need. And even evidence-based medicine has not given us information that really is helpful, and I'll describe kind of how that happens. And so the best we have today is what's been described on this panel in this session is a shared decision process where we don't want the patient to just be compliant and do what we tell them, but we want them engaged so we can help figure out what's best. And we try to do this in a team approach, including the patient and family. And as has been described, understand goals and fears, patient history, and an area that I think is going to have growing importance, the patient's general emotional state, their cognitive state, has a major influence on outcomes. Things we're learning, we really have tried to rely on reductionist science, and more evidence is coming out that the paradigm we've been using really isn't applicable. This book talks about the need for us to really learn from every patient that we see, really have a learning system in place so that we can get feedback and use that feedback to learn and improve. A book that came out recently, I think, had a story in it that helps explain some of our incompleteness in healthcare. This is from Todd Rose, The End of Average, and he just talks about the early days of the Air Force in the United States when planes were crashing every day. And on the worst day, 17 planes crashed. And this was not from combat, this was just regular exercises, and they couldn't figure out why. They thought at first it'd be human error or mechanical failure. They finally discovered the reason. When the planes were being designed, they had over 4,000 pilots lined up, and they did over 120 biometric measurements. Head circumference, arm length, waist circumference, leg length, and they built the perfect cockpit for the average pilot. The problem was there was no average-sized pilot, and sometimes the pilots fit so poorly into that cockpit that it led to crashing the planes. And unfortunately, this is what we do in healthcare today. In 2018, we try to fit the patients into the average treatment. And really, we have complex biologic variability we can't control. And if you go to the textbook, Introduction to Standards and Standardization, you learn that the true definition of standardization is not uniformity, but optimal variety. And this is what we need to get to in healthcare, to understand the patient subpopulations and patterns, to understand optimal variety of treatment to match for the correct subpopulation of patients. And we have this unbelievable complexity in our world of healthcare. We have so many different meshes, different techniques, even non-mesh repairs are many variations. And we need to understand how to deal with this complexity better in healthcare. And we see this influence from outside of healthcare, the lawyers, and I can tell you this is not helping our patients. They're getting misinformation and in many cases increasing their anxiety level, and they're getting negative cognitive neural wiring in their brain that results in poor outcomes. There is growing evidence and peer-reviewed publications about this increase in complexity and the fact that we can't know what's best for each patient using the reductionist science paradigm we're currently in healthcare. And in reality, we try to pull out one factor and one outcome measure and try to prove or disprove a hypothesis or a relationship, and that would work just fine if the assumptions were met that are required for this to work. That is, nothing ever changes, that we know and can control all variables, and that the results will be generalizable to all local environments. And I think we're learning that clearly these assumptions can never be met. And so now we're beginning to get some evidence published that says we need to move to a more complete scientific paradigm and use tools like measurement and continuous improvement with feedback loops from complex system science to better understand how to deal with this increasing complexity. We do have now a published policy statement at the University of Tennessee Medical Center that distinguishes complex system science tools from traditional reductionist science, and that when you do that, when you're measuring your outcomes and learning from them, that it's exempt from HIPAA and inappropriate to submit for IRB. So this is now public policy. And the regulatory policy is changing as well. The 21st Century Cures Act has become law. And in the working paper that was recently published, they talk about the future will be using complex adaptive methods and real-world data to regulate what's on the market, which is a much more complete scientific application than what we've done in the past. We also want to understand what's happening in the body. As I said, there's complex variables, and when we put mesh in a person, it doesn't do the same thing in each person. And this is how I learned about complex system science, because up until about 15 years ago, I thought that as long as you place the mesh well, that it would be inert and do what it's supposed to do. But in reality, we've seen through analysis of mesh after explanting from the body that there's actually complex and variable interaction with the body. And what this does through equipment that can measure thermal changes, mechanical changes, degradation. One example is a compliance test where we push the mesh through a slot at a constant force to measure the work required to do that. We see number one is out of the package, the pristine mesh is very compliant. But when we measure the compliance in various patient mesh explants, we see incredible variability, up to 10,000 times more work required. But in some patients, it's just the same as out of the package. The compliance is just as good as it was before it was implanted. And so the science of systems and data is about measurement and improvement. And I would say the most important thing we need to measure and tie back to our patient options is the measurement of value, cost, and outcomes coupled for the whole cycle of care in each definable process, in this case, inguinal hernia repair. And again, more and more is being published about the need for us to apply learning systems to our real patient care, not some isolated, controlled attempt to learn in a reductionist model. And so when we think about these systems and data science principles, we know that there are different options for different patient subpopulations. We need to discuss this with our patients, talk about watchful waiting, talk about lap and open repairs, talk about mesh and mesh options. And more, because of the awareness on the internet and through social media, patients are learning about this and sometimes learning misinformation. So it's going to be up to us to try to better describe this with our patients. So in the decision to have a non-mesh repair, even if mesh might benefit a patient, I go through the process, and we as a hernia team go through the process of explaining to the patient the pros and cons. The patient needs to be okay with an open incision. They need to be okay with possibly a higher recurrence rate. Until we get the data and understand subpopulations, we aren't going to know if they're in a group where the recurrence rate's very low or if it's higher. And they need to be okay with a longer recovery period compared to a mesh repair or a laparoscopic repair. They may have a little more pain and a little longer recovery based on what's available in the evidence. And especially, they need to understand the pros and cons of having a mesh in their body and see what's right for them. So I think when a patient presents and they're concerned about mesh, they understand the pros and cons, we offer a non-mesh open repair. And I think that's a fine choice as long as everybody's understanding, again, the pros and cons of those choices. So in summary, I think we're learning that we're in the process of a paradigm shift from what we've always done and what we believed was science with averages and try to push one right answer for patients. We're learning that we need to have a multidisciplinary team approach in a learning health system and use the tools of system science where the assumptions required for system science tools to work are constant change, biologic variability, and the fact that in each local environment there are variables that matter and it can change outcomes because of those local environmental variables. We need to engage the patient and family in this process, and I congratulate the leaders of this session for bringing the patient perspective in. I think it's uncomfortable at first, but it's very necessary, and it's a perspective that has a lot of value as we apply these learning systems and data science to measure our outcomes. And it's these transparent outcomes. When we can measure value of the care we're providing and learn from it and transparently show that, I think that'll lead to a sustainable healthcare system. Thank you very much.